You're listening to Everyday Evidence, presented by the American Occupational Therapy Association, helping the occupational therapy practitioner apply evidence to practice. Here's your host, Matt Brandenburg.
All right, on today's episode, we are joined by Stephanie Tsai and Elyse Peterson. Stephanie and Elyse, thank you so much for being on the show today.
Thank you so much for having us.
Of course. I'm excited to get to know you both a little bit and learn from you about occupational therapy in the ICU, something I'm not super familiar with. Before we dive into it, could you introduce yourselves to our listeners briefly?
Sure. So my name is Stephanie Tsai. I'm an associate professor of clinical occupational therapy at USC, practicing primarily at Keck Hospital of USC. See patients of a variety of diagnoses, but definitely specialize in folks who are recovering from cardiothoracic surgeries, as well as patients who have like end-stage heart failure and are undergoing advanced heart therapy interventions such as heart transplant and mechanical circulatory support.
Excellent. And then my name's Elyse Peterson. I am also an associate professor of clinical occupational therapy at USC, working at Keck Medical Center, also similar to Stephanie, seeing patients throughout the hospital, but specializing in critical care and patients in the ICU, also with patients after cardiothoracic surgery, patients on mechanical circulatory support, and heart failure of varying stages. So thank you for having me.
Of course. It's my pleasure. I'm honored to meet you both and learn about the work you do at the Keck Medical Center. Specifically in the ICU, you both were authors on a publication in the American Journal of Occupational Therapy titled Occupational Therapy Interventions and Early Engagement for Patients in Intensive Care, a Systematic Review. That's going to be the main focus of our discussion today. I have limited experience and exposure to ICU. Through reading your article, through some of the exposure I do have, it's pretty clear that ICUs are noisy, fluorescent, and unfamiliar environments that can negatively affect patients' mental and physical well-being. Patients experience ICU trauma, muscle wasting, weight loss, pain, and an increased risk for delirium during their stay. ICU survivors often leave with physical weakness, cognitive changes, and decreased participation in daily life. So I'm really excited to discuss how occupational therapy practitioners provide patients with opportunities to bridge the gaps between their former identities, current selves as patients, and potential future beyond their hospital stay through holistic care and a novel term that you propose in the systematic review, early engagement. Can you start by describing for us what happens to occupational performance during an ICU stay?
Yeah, for sure. So kind of like you were mentioning in that lovely introduction, the ICU is a really, really unique practice environment. It's exciting, it's dynamic, but also can be, really intimidating and really scary. The ICU is really a place where care providers are treating patients with critical and at times life-threatening illnesses. So there can be a lot of life-saving medical interventions that are happening, but they also come with challenges that can impact patients' occupational performance. So if you walk into an ICU room, it's pretty common to see a lot of weird machines, things that are alarming, things that are beeping. Patients' vital signs are constantly being monitored. They could be hooked up to, IVs, cables, specialty equipment like CRT machines, tube feedings, drains, even mechanical ventilators. So all of this creates this really, kind of busy, chaotic, strange environment for our patients to be in. And on top of all this, our patients are in the ICU for a reason. And so they're hooked up to all these machines, they're hooked up to all these things because there's a lot of challenges that are significantly affecting their health. With all this happening, our patients are often spending a long time in bed. And this could lead to kind of what you said earlier, Matt, like this muscle wasting, decreased strength, decreased activity tolerance, pain, and so much more. The combination and sort of interplay of all of these factors and things can negatively impact their performance, but especially with regards to participation in activities of daily routine, activities of daily living and their daily routines, mobility, getting out of bed, walking around. It can also affect patients with their coping and being able to adjust to being in the hospital and facing their current state of their health.
Wow, there's so many kind of unique factors to consider in the ICU setting. Um, you mentioned there's machines, there's ventilators, there's drains. These environments are noisy, disorienting. What risks do those environmental factors create in this setting from an OT lens?
Yeah, good question. Building off of what Stephanie was talking about, it's such a foreign environment. You've got the sounds, you've got fluorescent lights, you have unfamiliar people who are constantly coming into your space or your hospital room. People are coming in and doing things to you. You really lose this sense of self. You lose your routine and behaviors that can help people feel like themselves. You might also be on multiple medications and things that also are not making you feel like yourself. You feel very sick. So the environmental factors being the lights and the sounds are a huge component of it, but then also the other environment, the people around you too.
Yeah, and I think piggybacking off what Elyse was saying, all of these equipments, these people coming in and out, this space that's really foreign, it can lead to a lot of disruptions in your daily routines, including sleep. Just kind of speaking just from memory, one of the biggest things that our patients complain about in the ICU is like, oh, I didn't get much sleep last night, or oh wow, I got like 3 hours of sleep, and that was an accomplishment. So sleep is definitely one that gets disrupted pretty quickly in the ICU. But on kind of a more serious note, when our patients aren't sleeping well, this could potentially lead to ICU delirium and disorientation and confusion. And then kind of what Elyse was saying, just, everything is happening to you. People are coming in and things are happening on your behalf. So there is this loss of control and autonomy. And then with all this, it's really common for our patients to feel like really stressed and really anxious being in the ICU.
So much to consider and so much going on in the lives of these patients. What impact could these factors and circumstances have on long-term health if they're really not addressed during their ICU stay?
Yeah, that's something that's really coming out with a lot of research currently. Research is showing that over 50% of survivors from the ICU or prolonged ICU stays can experience what they call post-intensive care syndrome, or also known as PICS. And PICS has been shown to really have some long-term physical effects, such as weakness, reduced mobility, fatigue, and functional decline. And then on top of those physical effects, there's also risks of cognitive dysfunction, including memory loss, poor attention, decreased processing speed, impaired executive functioning. And then on top of the physical and cognitive effects, there's high rates of mental health impacts post-ICU stay, depression, anxiety, PTSD from this time in the ICU. And then, as Stephanie was mentioning, sleep disturbances that can occur after the ICU stay are really common in this population due to everything they've experienced. Translating to overall health and occupational performance long term, again, there's a significant risk of permanent functional decline or inability to return to work and challenges in returning to those occupations that patients previously enjoyed. As discussed in the article, early rehabilitation, engagement, mobility, these are all so important and valuable to mitigate the risk of PICS and try to optimize our patients long term.
Thank you. I love how you introduced early engagement in your article as a way to mitigate some of those risk factors for PICS and improve overall long-term outcomes. That's, what we're looking for with healthcare. And I think it's so unique that OT can contribute this to an ICU setting where the first thing most people consider is life-saving medical interventions, which, yes, are necessary and amazing and wonderful, but have a long-lasting impact after the patient has returned home, months, years down the road. Tell us about early engagement. How is that different from early mobilization?
Yeah, so we are really excited with this article to introduce this term of early engagement. So, for folks who are working in the physical rehabilitation realm, especially those in the ICU, there is a lot of buzz and a lot of research out there about this concept of early mobilization. So their early mobilization refers to like when you initiate movement and exercise early on during an ICU stay, especially while folks are on, all the specialized equipment and things. But when we were kind of thinking about this term, we realized it really only captured a small part of what OT can bring to the table with this population. So we introduced the term early engagement, and we define it in our study as this occupational therapy interventions in the ICU that promote overall patient participation in their care and occupations. So this, again, not only includes early mobilization, but it extends to other aspects of OT practice, including performing ADLs, occupations or activities of interest, interacting with members of the team and loved ones, psychosocial coping, and really empowers patients to actively participate in their care.
I love that. That's such a core component of occupational therapy in general. And I love how it's applied in this setting. If the patient is an active participant in their care, outcomes are going to be so much better. What were some of the other factors that motivated you to introduce this term and then to examine, the strength of evidence for early engagement interventions provided in the ICU?
Yeah, I think when we were first envisioning the idea for this systematic review, we, as mentioned, realized there's so much literature and conversation happening around this concept of early mobilization, but that term only refers to one aspect of OT practice. It's only the mobility piece. And certainly while mobility is important, there are other aspects of OT that are also very important in this setting, such as ADLs, participation in occupations and activities, navigating roles and establishing new routines, psychosocial coping, interacting with family and friends. So then we really brainstormed and looked up different terms and found that the concept of engagement and the definition used in the healthcare literature as being this collaboration between a patient and clinician that really enables the patient to be involved in their care, and we feel like it better captures the holistic approach of OT.
One of the challenges, though, of introducing this new term of early engagement and just engagement as a concept is there aren't really any formal outcome measures looking at this. Similar, in contrast to how there would be with mobility, which I think why there's so much literature behind mobility, engagement's a little bit, difficult to really pin down. And so with our previous definition in mind, we use this literature systematic review to look at the literature for evidence of engagement in the ICU, including OT interventions targeting ADO participation and functional cognition.
I think also this is a little bit of a stretch, but healthcare in general historically has been more reactive. I think there is a shift towards trying to be more proactive and preventative, increased emphasis on primary care visits, preventative tests, and things like that. Well, early engagement can possibly be seen as the ICU form of prevention for PICS and some of these long-term effects that we're seeing ICU survivors experience.
Wow. Talk about a light bulb moment, Elyse, that just opened my eyes to this new perspective of prevention in the ICU and mitigating some of those long-term risk factors through early engagement and through collaboration and care and a connection. I think that's such a value that occupational therapy brings, is connecting with patients on an individual level, considering their context, their environment, their previous experiences, everything about them that they find meaningful. How beautiful to study how it applies in this context through a review. How long have you both been kind of practicing early engagement, or what have you seen in your experience at Keck using early engagement?
Yeah, I think so. I've been at Keck, it'll be 13 years this summer. And I think I have spent most of my time in the ICU, and I started in the ICU, within the first year of my career. And I think it's something that has just evolved over time. I think feeling more empowered to have more of a voice, and then really developing relationships with the practitioners in the ICU and the patients, the practitioners, the other disciplines mostly do see the value of OT. And so it's really just, like I said, feeling empowered to how far can we go here? And obviously we recognize the power of OT. So appreciating all the wonderful work we can do and learning from our patients and building on the wonderful profession and services we can provide to our patients.
Yeah, for me, I've been at Keck, I think, about 8 years now, give or take a few months here and there. And similar to Elyse, kind of thrown into the ICU within like a first year or so that I was really on my own and practicing, and it's been great. Similar to Elyse and her experience, I think it's something that has developed over time. We have an amazing relationship with our nurses and our medical team and the physicians. They all can see the value that OT brings to the table. I think what was really exciting about the study was I think we all know what we're doing. We all know how it benefits our patients. We can see it. We can see how they're reacting. We can see how our patients are engaging and responding. But being able to put like a formal term to it that we can hopefully start using in practice and kind of spread the word out there that OT is involved in engagement. I think it'd be a really exciting direction for OT practice in the ICU in the future.
I love that. Thank you so much for sharing, your lived experience with early engagement. And I agree. Let's shout it from the rooftops and spread early engagement. Thank you for contributing to such a wonderful review that introduces this topic. I'd love to dive into some of your research process and methodology with that. Maybe if you could give us a little bit of background on how you made the connection to do a review of this topic that led you to find over 5,000 studies and then kind of whittle it down to 9 as part of this review.
Yeah, certainly. So obviously you can tell Elyse and I are pretty passionate about this population. And so we really wanted to dive into literature, see what's out there, see, what are the gaps in things and kind of figure out where we go from here. So, but the two of us, along with our co-author, Dr. Morgan Smith, a super shout out to her, even though she's not here. She did a lot of work with regards to creating, our search terms, going through the databases and articles and screening over 5,000 studies, as you mentioned. So after Morgan did the initial screening of all of the articles that we found that came up, kind of whittled it down to about 50 articles that were, maybe kind of fit, maybe not. So we all kind of read through them. We saw if they fit our inclusion-exclusion criteria. And then we ended up with our final 9 articles that were featured in our study.
And I think throughout the whole process, as we narrowed it down there, what really surprised us, or also perhaps didn't surprise us and is what inspired this review, was how little literature there is out there that captures occupational therapy specific interventions. So that was one of our main inclusion criteria, was that the article had to mention an OT specific intervention. So, and there were so few related to early engagement, even when we were looking for interventions related to ADLs, sleep, coping, and cognition. So I think seeing firsthand how difficult it was to find OT-specific interventions in the literature really reminded us of what we already know. We need more evidence in the literature that captures OT outcomes.
That's so important. Sorry, I'm almost at a loss of words because I hear that the medical team understands OT's value and OT's role so well in this setting, but the literature almost doesn't reflect that. And your paper kind of touches on that a little bit. You cite studies that found little distinction between OT and PT services in the ICU. You mentioned how it's important to distinguish OT-specific interventions from general rehabilitation literature. Why do you feel it is so important, especially at this moment in time?
Yeah, I think that also relates back to the concept of early mobilization and how that has gained so much traction. And I think many of the disciplines we work with recognize the value of early mobilization. But again, that only captures a small part of what we do as OTs. And so while OTs and PTs, we often collaborate within the ICU, we think it's especially important to have some distinction between the unique perspective and services that OT provides beyond this mobilization concept. OTs and PTs, we are different professions with different lenses. We both certainly have common goals of helping patients discharge from the hospital and return to living more independent lives. But we do have different theories and strategies of how to get there. So I think patients can certainly benefit from both strategies. research does show benefits to both OT and PT, so receiving both distinct services is beneficial to the patients in these different ways.
Yeah, and then speaking anecdotally, just thinking about our own experiences, when we see patients in the ICU along with our PT colleagues, we're often weaving in OT specific interventions while we're with them. So, for example, we could both be helping patients be sitting edge of bed, but then, we're doing so as OTs to help patients, do grooming or hugging family members. If we are working with PTs to transfer patients to a chair, we're always kind of, with the goal of, okay, maybe you can be in the chair to eat all your meals, or maybe you can just be up for an hour or two to, engage with the team and engage with your loved ones. Similar to transfers, we're often trying to work on transfers to a bedside commode so that patients can use the toilet, better than using the bedpan for sure. And then also, if we're helping patients walk in the hallway or we're helping them stand, we're always kind of thinking about what is this in service of, going back to their occupations. Maybe they're doing that so they can practice their golf putts, or going back to, walking around for a mile that they like to do at the park. So things like that. So kind of what Elyse was saying, OTs and PTs, we work really closely together. But as far as the OTs go, that end goal is always, getting back to occupation and getting back to those meaningful activities.
Absolutely. I love that. And you whittled it down to those 9 studies that were met your inclusion criteria. Only 3 of those 9 had OT authors. What does that tell us about research leadership in this space?
Yeah, there is definitely a need to have more OT research out there. There are so many challenges to performing research in the clinical setting, particularly in the ICU, where there's all this medical complexity, there's specialized equipment, and patients with critical illnesses.
And I think in this setting, it can be especially tough to isolate different variables and really capture OT outcomes. But of course, it's important for OT practitioners to conduct research and really build this body of evidence to support the amazing work that we do, not only in the ICU setting, but across practice areas and populations.
What a wonderful first step in releasing this systematic review that can now be used, as a citation, as a blueprint, as a reference, and hopefully an inspiration to other practitioners to explore and publish some of what they do in this setting. I love in your review the descriptive summaries that revealed 3 categories of occupational therapy interventions supporting patient engagement while in the ICU. ADLs, physical rehab, and cognition. I'd love to go through the evidence you found for each of these categories one by one, if that's all right. What does the evidence tell us about early ADL engagement in the ICU?
Sure. So from our systematic review, we found moderate evidence supporting ADL engagement in the ICU with interventions that were mentioned, including grooming, eating, and commode transfers. And what we found in the literature was that the ADL interventions in the study were often conducted in combination with other early engagement interventions. So kind of similar to what we were talking about earlier, these ADL tasks were often performed in conjunction with early mobilization. So again, for example, patients would often be sitting edge of bed while completing some kind of self-care task, or they'd be performing a functional transfer to a commode for toileting. And this makes sense because we need movement to perform ADLs. So if we're working on mobility and strengthening in combination with activities of daily living, again, that's sort of a natural fit. But one of the studies we wanted to highlight was the study done by Alvarez and colleagues in 2017, where they found that ADL interventions in combination with mobilization and cognitive interventions help to increase functional independence at discharge compared to the control group. So again, there were some studies that mentioned ADL retraining. Some of the studies mentioned it, but didn't really specify which ADLs. So there's definitely a need to really further explore this area and kind of add to that body of literature to support ADL engagement in the ICU.
Absolutely, especially with such positive outcomes from some of these early studies. Who doesn't want increased functional independence at discharge? You've already given us a bit of a peek into what some early ADL engagement interventions look like. Are there any additional kind of strategies or tips you recommend clinicians implement to make sure they're addressing early ADL engagement?
I think one example we can give is, it really depends on what level the patient is at when initiating intervention. For example, you could take a simple grooming task, such as having a patient wipe their face with a washcloth, or performing oral care with a toothbrush, or even oral rinsing with a suction brush. We have special shower caps that patients can use to wash their hair. And the beauty of, while it looks like a simple grooming task, is that it can really be graded by being done in different positions. So, these can all be done with the patient still in bed. Maybe you raise the head of the bed up. Maybe the patient can tolerate sitting in cardiac chair position, or perhaps they can be sitting in a regular chair, or if they're doing quite well, walking over to the sink. We really like this one because it can help patients regain some control and some autonomy within the ICU. It also helps patients feel refreshed, feel a little bit more like themselves. And then also initiating this establishment of a daily routine and orienting patients to the day and time when one would maybe typically be performing grooming tasks, if that's something perhaps they usually do in the morning, for example. So really just empowering patients to get back to doing some of these normal daily activities, I think, is one of the big powers of ADL engagement tasks or interventions.
I love that. Thank you, Elyse. If you were speaking to, let's say, an ICU administrator, how would you really verbalize or communicate the importance of ADL interventions in a high acuity setting?
Yeah, that's tricky, but so important. And as we know, engaging in ADLs is so important, especially in the ICU. I think we often take for granted that we are able to have our normal daily routines where, we wake up in the morning, we brush our teeth, we eat our meals, we get dressed, we shower, and we're able to feel, quote, human. In the ICU, a lot of this goes away very quickly, whether it's due to the foreign environment, as we talked about earlier. Maybe the patients have decreased strength or activity tolerance during their phase of critical illness, simply the loss of autonomy, or a combination of all those things. But having patients engage in ADLs while in the ICU really can give them purpose and a sense of normalcy, while also building up their strength and being able to do those tasks and become more functionally independent. I think it can also help patients reorient to their environment. And then, as we touched on earlier, in terms of the proactive and preventative approach, we know that engaging can hopefully reduce the risk of ICU delirium and other negative health outcomes that can occur after an ICU stay.
Yeah, from our experience, just kind of thinking about it, we've had so many patients express feeling a whole lot better after being able to do these, quote unquote, simple tasks like brush their teeth or wipe their face. It's so simple, but I think it does help give them hope that they can one day go back to their routines and their occupations, which can be so powerful when in the ICU setting and facing these serious health challenges.
Yeah, I think oftentimes patients in the ICU, they're hooked up to so many things, they don't even know what they can do or how they can move. I think there's a lot of fear involved. If you've got multiple IVs in your arms and lines in your neck, and you don't even want to lift a finger. But then if you have an practitioner come in and offering to brush your teeth, what a wonderful opportunity. It's, oh my goodness, I can move. I can do these things, and just feeling any sense of self again is so valuable.
Absolutely. Thank you, Stephanie and Elyse, for sharing that insight and what you've seen, I'm sure, on almost a day-to-day basis with what you do.
We'll get back to our interview right after this quick word. We try to make research more applicable and more consumable for our listeners, and completing the survey that we mention on each episode helps us to do just that. AOTA members are now eligible to receive 1 contact hour for listening to an episode of our show and completing the survey. The survey is still only 3 questions long and can be found by following the link in this episode's description. Get yourself a contact hour and help us to improve the show, improve the resources AOTA provides to its clinicians, and improve the application of evidence to practice in our field. Now back to the interview.
All 9 of the studies included in your review had an aspect of physical rehabilitation. Where does occupational therapy uniquely contribute within some of those physical rehabilitation interventions, such as therapeutic exercises and mobilization programs?
Kind of talked about this earlier, but one of the superpowers of occupational therapy is the ability to tie everything back to function and occupation. So while physical rehabilitation, strengthening, and mobilization are important, occupational therapy practitioners are able to provide that context for which these programs occur and incorporate them into ADLs and other tasks. So, for example, when we're in the ICU, we're engaging patients in bilateral upper extremity exercises. The ultimate goal could be strengthening in preparation for ADL participation. So, you're working on moving those arms up and down, working on strength. But again, we're trying to build up that strength and range of motion so that they can do things like upper body dressing, feeding, grooming, or even other tasks in the future, such as playing the guitar, writing in a journal, or gardening, things that patients need to and want to do in the future. And then even for something like progressive mobilization, where the focus of the session could be on helping patients progress from sitting edge of bed to standing to performing transfers and then to walk, occupational therapy practitioners can help integrate all of these tasks within the context of occupation, such as building towards performing toilet transfers, being able to walk around in the household or community distances. So again, just making sure everything is kind of relevant and not just doing exercises in isolation for the sake of strengthening, but making it more relevant to the patients, especially in the long term.
I love that. That's such a beautiful way to, acknowledge maybe some of the fear that a patient might be experiencing. And like you both said, let them see themselves returning to those meaningful occupations and giving them the hope and empowering them to do so. What are some tips and recommendations that you would give the practitioners to more fully collaborate with other professions in early progressive mobilization and therapeutic exercise?
Yeah, that's a great question. Working in the ICU can definitely be intimidating, but with all those lines and equipments and everything going on, it definitely takes a village to help patients move. So definitely need to take into consideration the patient's medical statuses and everything that's going on. So I think one of the biggest tips is to have a really strong multidisciplinary collaboration and involvement. So this just, for example, could entail, before even seeing the patient, checking in with the physicians to determine any kind of parameters. Some of our patients have blood pressure goals. Some of them are able to go up and down on certain medications that could allow for movement. Some patients have lines that are in really inconvenient locations, some of which include femoral lines, lines like right in the hip and groin area, that in the past, were sort of like a hard stop for moving. But literature and technologies have made it so that we can start getting these patients up and moving even with those lines present. But definitely good to get clearance and the okay from the physicians and the team before doing so. And then after doing that, touching base with the nursing staff who are, at the bedside. They know the patients really, really well. So checking in with them, trying to figure out how the patient's doing that day, determining the best time of day to work with them, and setting them up for success with administration of any pain medication or blood pressure medication is needed. And then, of course, collaborating with our PT colleagues just to optimize the patient's participation and engagement in out-of-bed activity, especially if the patient has limited activity tolerance or if they require skilled two-person assist to make sure that they're safe with functional transfers and mobility.
I love that. Those are excellent tips. Awesome recommendations. Thank you, Stephanie. I want to shift now to some of the findings surrounding cognition and delirium. You've mentioned cognitive impairment after a stay in the ICU is common. How have you seen that really present? What are some of the cognitive, difficulties or deficits that people are experiencing after their stay in the ICU?
Yeah, it really varies. And I think it can be, it ranging from mild to severe, depending on medical events that occurred. Some patients do experience strokes during their stay, which can have a full gamut of presentations. And then it can also be a much more mild case, but also detrimental. Maybe they had some sort of hypoxic injury after a heart attack or something like that, for example, which can present in very different ways. But yeah, it can run the full gamut. It can impact anywhere from executive functioning, memory, attention, motor skills, vision. Full gamut of neuropresentations.
Would you say that sometimes cognition is overlooked in acute medical environments? And if so, why do you think that is?
Yeah, I think cognition is often overlooked. I think the issue here is that cognition is often intangible. It can be hard to see. Patients can be good at disguising cognitive issues. And on the flip side, physicians maybe don't necessarily like to admit that their interventions or care may have contributed to some cognitive issues. It really feels like a taboo topic. I think cognition can also be hard to test for in the clear, objective imaging way that physicians like to operate in. For example, an X-ray clearly shows a broken bone, a blood test can show an infection, but a CT scan might not show neuroinsults that are causing mild cognitive impairment. So it can be really difficult to describe and discuss. I think physicians also like to attribute cognitive deficits to short-term difficulties, such as lack of sleep or effects of medication. Delirium is also used as this blanket term as the reason for why patients may be experiencing cognitive deficits. I've noticed if family brings up cognitive concerns, they're often told that the issues are due to ICU delirium. And certainly, while there may be components of delirium in the patient's current state, it's much easier for physicians to attribute all cognitive issues to delirium, as it can then be passed as a temporary state that will improve post-ICU stay or hospital stay once the patient is removed from that hospital environment. So I think it really, this term of delirium or applying this diagnosis of delirium helps physicians in that it removes responsibility that the patient may actually be experiencing more long-term cognitive impairments.
Wow, that sounds like a serious concern. What do you recommend OT practitioners do to make sure cognition is addressed in a setting like this?
I think it's important that we, work with our patients and communicate with other practitioners as much as possible. Advocate for your patients. We know that addressing it can help improve it. Similar, the brain can be like a muscle. We need to be using it and addressing it. And if you receive pushback from other providers, well, you can continue working on it in sneaky ways within your interventions. But I think it's important to address it.
I love that. That's a good challenge to try and sneak in some cognition with every intervention. We've mentioned the Alvarez study that you examined and included in this review a number of times. That study showed reduced delirium with OT intervention. What might explain the effect that occupational therapy had in that study?
Yeah, so the Alvarez study was pretty unique in that it was a pilot RCT with an intervention and a control group, which again is pretty hard to find, especially in the clinical setting. The intervention group included patients who received standard care plus early and intensive occupational therapy within the first 24 hours of ICU admission compared to the control group who received standard care. So I think the key here is that the intervention group received OT services so quickly and early in their ICU stay. We've discussed how challenging an environment the ICU can be. And so, the longer patients kind of rest in bed and not engaging or participating in any sense of normal life can definitely be detrimental, especially as the days go on. It's also becoming well documented that ICU delirium is best managed by first prevention rather than early intervention. So if we can prevent it early from even happening, that would lead to the best outcomes. And so, by engaging with patients so early in their ICU admission, this could allow patients to maintain some sense of function, participation, and mobility that can help to offset some of the detrimental effects that delirium can cause in the ICU. And so the researchers in the Alvarez study, clearly demonstrated both early and intensive occupational therapy services helps prevent delirium, which again can set the patient up for long-term optimization of function.
That's amazing. Do you think you'll do a collaboration with the Alvarez study authors at some point?
We've quoted their study quite a bit, and it's kind of like now the shining star in our study. So may have to dig into that in the future.
Yeah, let's get an all-star team set up over here. Not that you guys aren't already all-stars, you definitely are. What would you say to clinicians working in an ICU setting or another setting where they're working with medically complex caseloads who still might feel a little unsure about cognitive interventions? Where can they begin? What can they do to start?
Yeah, great question. I feel like an area that can feel overwhelming too. I would recommend observing patients. Just start talking to the patients, trying to get to know them. We often have never met them before, so we don't know what baseline is. But I think it's so valuable just to try to get to know them and have conversations if possible. I think oftentimes physicians may come into the patient rooms and they ask the usual orientation questions, what's your name, what's the date, where are we, which the patients may or may not know, but have probably been asked multiple times already that day. So as OT practitioners, we can try to get beyond those superficial questions and potentially uncover some cognitive issues that could otherwise be missed. Not that we necessarily want anything to be wrong with our patients, but you can feel a bit like a detective in trying to uncover potential issues by diving deeper than just the superficial orientation questions. So I'd encourage, having conversations, and that can be more informal just to try to understand a patient's line of thinking. I would also suggest create a bank of questions to ask, maybe, some discussion points to have. And again, it doesn't necessarily need to be formal, but just consider the various categories of cognition and how we can explore patients' functioning within those realms through conversation or activities. Alternatively, you can conduct cognitive assessments if you're looking to put objective numbers and results to cognitive functioning. Assessments can also be nice to hone in on specific problem areas or gain more insight into the severity of cognitive deficits, as well as can be used to track change over time. I think another, we talk about sneaky interventions. One sneaky intervention here is to get patients to take more initiative in their care. I may ask, oh, what's happened in your day already? What'd you have for breakfast? What's coming up in the day? What do you still need to work on? Or what do you want to work on in therapy today? So this can really help patients feel more like an active participant, not only during the OT session, but also during the other 23 hours of the day they spend not with occupational therapy. And then it requires them to be more attentive, to work on their memory and process situations around them, to hopefully take more initiative and be less passive in their care. In terms of designing other specific interventions, I think it's so valuable to consider where the patient is at. So, for example, if they're low level and struggling to sequence activities, start with something they've probably done thousands of times, such as brushing their teeth, and see if they can sequence that. Really trying to break the task down. Just hand them the supplies and see what they do with it. Or you can give them another activity with multiple steps and see if they can problem solve and follow multiple steps. I also like to print out pen and paper activities such as word searches, puzzles, Sudoku, etc., that patients can complete on their own time. And then going back to taking more initiative, you can encourage, ICU diaries are a big thing, or journaling about their experience, which can help not only their cognition in the moment, but also mental health long-term if they have something to look back on, and potentially help with their PTSD or depression or anxiety they might be feeling.
I love that. Those are such awesome recommendations and some wonderful creative questions to include as well. Stephanie, do you have a favorite question that you like to ask your patients?
Yeah, I was actually thinking about this as Elyse was sharing all these hot tips. One of my favorite ones is if the patient can remember what happened the previous day, or even like, do you remember what we did last time in therapy, whatever that was, and it's hit or miss. Some of our patients do remember some things. Some of them are like, oh yeah, we sat up on the side of the bed or something, or they'll acknowledge like, oh yeah, I remember you from before. And then you'd be surprised. There's a lot of patients out there who are like, no, I don't remember. So that can kind of clue you into something that might be going on, and maybe this type of patient might benefit from what Elyse was saying, like writing things down, keeping a log of things that are going on. But as OT practitioners, we tend to get to know our patients pretty well. We spend a lot of time with them. We get to know them and their likes, and sometimes their loved ones, and interact with them within the context of their patients. So sometimes we are the first ones to uncover that something might potentially be a little bit off. And then, trying to have those like sneaky interventions during our sessions, but also, sharing that with the team and what we're finding.
Yeah. That's a wonderful question, and a powerful way to build some self-awareness too, that can really empower and help patients be a part of their care and participate in that collaboration. Your study notes limited research on mental health, sleep, pain, and environmental modification. Why do you think these areas are underrepresented in ICU research?
Yeah, I think these particular areas, as well as some more, they can all be really difficult to research, as they are especially challenging to quantify. They often rely on subjective human experiences as well. So each and every human is so different with their various past experiences, their comorbidities, their baseline mental health, et cetera. Everyone's kind of coming from different places. So research in these areas can often be confounded by many different variables. It would be difficult to design a robust study for these areas, especially as isolated variables when you're in this really dynamic ICU setting. And the ICU itself is also very medical, and it can be really difficult to propose and administer alternative interventions or strategies when medical treatments always kind of take priority. So it is kind of hard to isolate these variables, as well as build different control and experimental groups to really get to the cause of these things. But definitely these are all areas of future research that might be really interesting to explore.
I'm glad you mentioned there are so many limiting factors in research. Let's say we took those out of the picture. If you could design the next big ICU occupational therapy study, what would you examine?
Such a good question, but also a very difficult one.
Yeah.
Ideally, we could conduct an RCT that clearly demonstrates the value of OT. RCTs are gold standards. The study design ideally would include, an intervention group which receives early and consistent OT services, and a control group which does not receive OT services, right? We're basically pinning OT against not OT, which would be really valuable to obtain functional outcome measures, hospital metrics such as length of stay, days in ICU between the two groups would be so powerful to demonstrate the value of OT. But I think one of the big challenges with this, there's multiple challenges, but one is that it feels morally wrong to withhold OT intervention to the control group, right? We're already shouting from the rooftops how valuable this is. So then who are we to withhold that from people who need us so desperately? I think it's also difficult to foster the consistency in interventions that would be required of a gold standard RCT. The ICU world does not work in controlled status quo timelines, such as research studies and procedures love to follow. One day a patient can be doing great, the next they can be intubated and crashing. So this simple example really highlights the difficulty in conducting formal interventions and research studies in this always changing environment.
Yeah, I think if we could take away all those factors, that would definitely be such a really cool study to do. But like Elyse said, it's really, really challenging to do a true RCT and, to assign OT to certain people and not OT to other people. But I think realistically, future OT research in the ICU, especially for people wanting to really look at early engagement. They could look at expanding on certain aspects, such as ADL participation. That'd be a really, really great one to look more into. Sleep, coping, and then just overall occupational participation in greater depth.
I love that. Those are some really excellent future directions of research. I know I'm feeling inspired from our conversation, and I hope our listeners and future OT researchers are as well. How have you seen early engagement align with value-based care and long-term cost reduction at kind of a more systems level?
Yeah, I think our healthcare system continues to get squeezed financially, which is making it increasingly important to justify our value. Hospitals are interested in optimizing their financial efficiency. So if we can demonstrate our value in improving hospital metrics, such as discharge disposition, length of stay, days in ICU, that can really entice hospitals to invest in OT and makes it easier to justify OT positions. So I think this review demonstrates that early engagement does add value in decreasing rates of delirium, improving functional status, which all contribute to reducing hospital length of stay, and overall improving outcomes for patients and therefore the hospital.
I love that. And those are some excellent suggestions and recommendations too for how clinicians can advocate for more increased occupational therapy presence in ICUs and in hospital systems. What other recommendations would you give for clinicians who are looking to grow their scope or grow their impact in these spaces?
Yeah, I really think a multifaceted approach is best long term. At the grassroots level, OT practitioners currently in the field performing excellent, quality patient care every day, practicing early engagement, promoting mental and physical gains really helps other professions see our value, not to mention the patients and family and friends that witness our value in their own personal experiences. I think establishing relationships within your own facility so people get more familiar with the great work of OT and recognize the value is important. I think I would, just encourage providers to dream big, encourage occupations and early engagement with the ICU. This can really attract attention from other providers who get excited to see their patients engaging in new activities. I think we all appreciate the power of occupations, and patients are often able to stand for longer or might have improved strength when they're motivated to participate in their favorite occupation. So we as OTs are so well equipped to help optimize a patient's function while they're in the ICU. One of my favorite things is helping patients engage in occupation. Maybe that's with a soccer ball or golf club or Connect 4 game. And when I walk around the hospital with something like that, you'd be surprised at how many questions I get carrying something that is not medical, something that everyone associates with fun. I think it naturally prompts interest from other providers. It's good for the patients and the interventions. And of course, all other providers generally want their patients to improve. So it really generates a lot of excitement. So I think, it prompts those conversations and establishing the relationships. And then OT practitioners get affiliated with this fun but improving and general positivity within the ICU. I think also, training and education is incredibly important to build skills to allow for some of these interventions to be done and to really advance our OT profession to, there's constant advancements in medical technology, and we as an OT profession also need to keep up with that. There's new devices, ICU practice is constantly changing. So we need to be adaptable in growing with these medical advancements to stay relevant and cutting edge and being able to treat these high acuity patients in the ICU. I think additionally, say by developing some of these relationships with other disciplines or hospital administrators, you can use articles like this to present to hospital leadership. If you open that door through some of your other work, maybe it gives you an opportunity to explain more. be involved within the hospital on various multidisciplinary committees to really get a seat at the table and demonstrate the value of OT. And then, of course, continuing to build and conduct research and disseminating the great work that we do as OTs outside of the OT profession is also incredibly valuable.
I love that. Those are excellent recommendations. And they really hit at the core of occupational therapy. I hope our listeners are feeling empowered and encouraged to be fun, to be creative, and to be competent on top of it all. I want to thank you both for completing this review on top of maintaining your caseload and working in a high acuity, high stress, fast-paced environment, contributing to a review like this. As you reflect on getting this review published, looking into the research, all the work that you put into it, how did this review change the way you see occupational therapy in critical care?
Yeah, thanks for saying that too. One of the challenges, of course, is always conducting research when we're full-time clinicians, doing the work too. But again, it's so important and so valuable that we're happy to do it. And we're just glad that, it got published and it's receiving a lot of this great feedback. So thanks for saying that. In terms of conducting this review, it really helps structure and put a framework to what we see and what we do every day. So we certainly recognize the value of OT in critical care before conducting this review, but we wanted to get a sense of what the current state of practice is and also where we are as a profession. And so this review really helped put language to some of the concepts, that we kind of encounter every day. And it can help us organize and communicate our roles as occupational therapy practitioners and focuses our goals as a profession. Doing this review really opened our eyes to the limited research out there that exists specifically related to OT in the ICU. So definitely, encouraging all the folks out there, for those who are working in this setting or those who are connected to the setting in any way, to continue trying to do research and build sort of this portfolio that really showcases the amazing work that we do in the setting.
I love that. That's so well said, Stephanie. I think all of us as OT practitioners, we feel the magic. We see the magic that OT can provide to patients in a collaborative and supportive setting. But having a template and having it in research and having a full systematic review that we can, cite and reference in advocating for our profession, that makes such a huge difference. What is one thing that you both hope clinicians take away from this review?
One thing that I want them to take away, I think more and more, the medical teams are kind of realizing what OT is, where the practice is headed, what are the benefits of having, OTs have a seat at the table. And so from this review, I really hope that it does inspire occupational therapy practitioners to feel empowered, to feel like they are valued and important, because they are. Working with our patients, we, like you said, Matt, we see the magic. We see it every day. But we're really hoping that this review can inspire people to advocate for the practice, to continue building the repertoire of literature, supporting our practice, and also just to continue doing the amazing work that everyone's already doing.
I love that. And Elyse, how about from you?
Yeah, I think just the, continuing to encourage and empower providers around us. If we can do something great in a day that generates buzz, and hopefully it can just keep growing from there. I think the interest that is piqued around this article and, doing this podcast, hopefully, even if that inspires one person out there to get more involved and do more in the ICU, that's a win. Hopefully it's more than just one, but the more we can build on the momentum, I think we all know and appreciate that OT is so valuable in this setting. And so generating some kind of excitement or buzz, and hopefully that can just carry on to more positive impacts with patients and overall outcomes.
Absolutely. Was there anything else that either of you wanted to revisit or share with our listeners?
Yeah, sure. I think just in general, especially, as Lisa and I, we have been working in the ICU for quite some time, but it wasn't always that way. I think for folks who are interested in practicing in the ICU and really want to, dive into this population, definitely just some tips. Get a good understanding of body systems and the medical background and everything. Get comfortable with lines and devices because you're going to be encountering those a lot. But also just have your OT hat on, being ready to do task analysis and grade activities. You'll be amazed at how much you're able to break a certain task down and help patients in the ICU feel successful with all those things. Communication is so important. Working with various team members and also communicating with family members. And then finally, for anyone, OT practitioners in the setting, just having compassion and empathy for the patients in the ICU, appreciating that this is a time where these patients can feel the most vulnerable and fearful about their overall health and future, and being able to hold space when needed for patients to cope and process their experience, while also being encouraging and being their biggest cheerleader when needed. It's such a unique and such a special thing that OT brings to the table. So again, definitely just on the same theme of encouragement, want to encourage all those who really want to start or keep going when they're working with patients in the ICU.
I love that. Thank you so much, Stephanie. Elyse, did you have any concluding remarks you wanted to share, or anything you wanted to revisit from our discussion today?
Yeah, I think one thing that I hope clinicians take away is I hope clinicians can feel empowered. I spoke earlier about dreaming big and incorporating occupations in the ICU. And back to the earlier discussion about the environment within an ICU, recognizing that it's an intimidating place, and it can be for both providers and for patients. And thinking about the patient perspective, there's all new people around them. And it's natural for anyone to feel overwhelmed and timid. Again, from a patient's perspective, people are constantly coming into their room and doing things to them, whether they're getting poked or prodded or who knows what. But OT is one of those few professions that collaborates with the patients and can help facilitate them being able to do things for themselves, or optimizing their function, or doing what they want to do, seeing what they can do. So our profession is so valuable in empowering patients to do what they want to do, to engage in anything they enjoy, and achieve goals for the day, to feel accomplished, despite possibly feeling like the odds are stacked against them when they're hooked up to so many devices, or there's so many beeps or alarms. So, we empower patients daily, and I hope this review and this podcast can empower clinicians to keep going out there and doing great work.
Absolutely. I hope that too, Elyse. Thank you both so much for being featured guests. It's been wonderful speaking with you, learning from you, and being inspired by you. So thank you so much for your time and for sharing your knowledge with us today.
Thank you so much for having us. This was so great.
Yeah, thank you.
Thanks for listening to Everyday Evidence. Tune in next time for more evidence-based practice insights and applications.